Welcome everyone, this is Cindy Lowen. I'm a dietitian and medical affairs manager at Nestle Health Science. I will be moderating today's presentation entitled SARS-CoV-2 Nutrition, an Evolving Perspective. I'm very pleased to introduce our speaker for today's program. Dr. Juan Ochoa is a trained surgeon, having completed his first general surgery residency training program in Colombia, followed by a second residency in general surgery and a fellowship in critical care at the University of Pittsburgh. Dr. Ochoa served as a tenured professor of surgery and critical care at the University of Pittsburgh and associate director for trauma services within the UPMC system. He maintained an NIH-funded laboratory throughout his academic career, focusing his work on studying arginine metabolism. As a physician scientist, Dr. Ochoa's work spanned the translational spectrum with significant contributions in the basic understanding of arginine depletion and its effects on T lymphocytes and nitric oxide production. Dr. Ochoa was Chief Medical Officer for Nestle Health Science North America from 2009 through 2018, while maintaining a limited critical care clinical practice at Geisinger Medical Center and adjunctive professorship at UPMC. Dr. Ochoa is currently the medical director of the SICU at Oster Medical Center in New Orleans. He continues to perform research and has published over 110 peer-reviewed manuscripts and book chapters. He currently lectures nationally and internationally, passionately advocating for the optimal nutrition care of all patients. It is now my pleasure to give you Dr. Ochoa.
Thank you so very much. It is an honor to give this presentation, and I hope that the work that we are sharing today is helpful in your practices and in addressing the needs of the patients with COVID-19. A disclosure of my relevant information is important. I will not discuss any proprietary or commercial information, and I am also an author in a number of these publications. All of the work that I will be presenting is either from peer-reviewed publications or from reputable websites, which will be disclosed on each slide. It is important to understand the objectives of this presentation. I will be talking about the characteristics and the physiology of the patients exhibiting SARS-CoV-2, as witnessed in New Orleans. I will discuss the unique nutritional requirements of these patients, and I will also identify the experiences that we have had in providing adequate nutritional support for the patients in the intensive care unit. To achieve that goal, I will talk about the clinical history of COVID-19. I will also look at how we are providing nutritional care, including a nutrition assessment and a nutrition intervention across the stay of these patients in the intensive care unit. COVID-19, as we all know, is a new disease. The first reports of a cluster of severe pneumonia cases was reported in the Wuhan province of China in December 2019. From there, the disease has spread worldwide so that only a few islands are left COVID-free. As of last week, there were over 1.6 million cases, which have unfortunately continued to increase exponentially, as we can see in this slide. And there have been now, as of today, over 180,000 deaths, and unfortunately, these will continue. So we have to prepare ourselves to take care of these patients the best way we can and to provide excellence in nutrition support. Let's go a little bit over the clinical presentation. We know that SARS-CoV-2 is the virus that causes coronavirus disease, or COVID-19. We also know that, or we believe that their period of incubation is about 14 days, but patients typically manifest clinical signs and symptoms within the first 4 to 5 days. Fever is quite prominent in these patients, and coughing is also quite prominent. it is characteristically of coughing, hacking cough, but these patients can also present with some sputum presentation about 1/3 of the cases. There are systemic signs such as myalgias, anorexia, and fatigue also observed in these patients, and unfortunately, in about 1/3 to up to 40% of the patients, shortness of breath can be a presenting symptom. Up to 80% of the patients that present or that are infected with COVID will have a mild disease. We do not know at this point the exact number of patients that are completely asymptomatic, and some reports can vary as low as 2%, some as high as 50%, so that remains to be determined. But we know that about 20% of the patients require hospitalization, mainly for severe dyspnea and hypoxia. And that when we do any imaging, either chest X-ray or CT scans, up to or more than 50% of these patients show some level of lung involvement. In about 1 out of every 5 patients that are admitted to the hospital, they will develop the need for critical care management, and they will develop enough multiple organ dysfunction to require critical care. Typically, more than 80% of the patients that are requiring ventilatory support end up on the ventilator, but this number is varying as we are learning more and more on how to take care of these patients. And somewhere approximately between 15% to up to 1/3 of the patients require renal replacement therapy. The initial death rate reported was about 2%, but is higher in certain countries depending on the patient populations at risk. What are the risk factors that we are seeing in COVID? And the number one risk factor is age. And as you see in this slide by the CDC, there is really a linear relationship in the development of severe COVID-19 and age. And that becomes a prominent issue in these patients. If you look at it, older patients also suffer from hypertension, and thus hypertension is a frequent manifestation or pre-existing condition in these patients. But one of the important characteristics, which I will focus a lot of my lecture on, is in the presence of a metabolic syndrome. These patients characteristically suffer from obesity, hyperlipidemia, and other metabolic illnesses, and frequently suffer from diabetes mellitus. Let's go in depth into these numbers a little bit more. If you look at it, while old age is very important as a risk factor for developing severe COVID, morbid obesity is a risk factor, but it is a risk factor for the younger patient populations developing severe COVID. And therefore, this has to be taken into account as we take care of the patients. The patient's overlying metabolic health is thus a major factor in the development of the severity of illness. It will also determine our plan of nutritional care. What else determines our nutritional care plan? If we look at most of our patients that arrive to the intensive care unit, most of them will develop at least some organ failure, of which acute respiratory failure is the most frequent, but we also observe myocardial injury, liver injury, and acute kidney injury. Let's talk about respiratory failure. When we started seeing patients a few months ago with COVID, we thought that this disease was mainly an adult respiratory distress syndrome or ARDS type picture, and that they would present with a characteristic of a dependent atelectasis of the lung, and that they could and should be managed by early intubation and by using lung protective modes of ventilation, as has been taught by the ARDS type trials. But we quickly discovered, and it has been a significant characteristic and reported by the Italian groups prominently, including the work that has been done by Luciano Gattinoni, that patients can present with hypoxia in a lung that is not stiff, that is with normal compliance, and the absence of a lot of disease in the lung fields. And he calls this a type 1 respiratory failure in these patients. And it is due to a redistribution of pulmonary blood flow. While this tends to be the early presentation in these patients, they can also evolve into an ARDS picture. And that evolution from one picture to the other can occur either because of mismanagement of the ventilator, because of superinfection with another microorganism, or because of worsening of COVID-2, and can happen characteristically by the second week in the intensive care unit. We propose that the nutrition intervention is different between these two phenotypical presentations of respiratory failure. The other thing that is prominent in these patients is that of thrombotic complications. It is said that the respiratory failure that we are seeing in these patients with type 1 presentation is caused by microemboli and microthrombi in the pulmonary artery distribution. But while we also see thrombosis in other areas, including that of deep vein thrombosis and the development of venous thromboembolism, and the development of pulmonary embolism. And we characteristically will see some abnormalities in coagulation. Up to 1/3 of the patients present with arterial thrombotic events. And this is quite prominent in this illness, so that right now, in most of our patients in the intensive care unit, we are providing anticoagulation. Hemodynamic instability is observed in virtually 100% of the patients that are intubated. And it is related to their illness as well as to the need for heavy sedation that these patients characteristically require. And thus, that is something that we need to take into account when we are providing nutrition support, particularly enteral nutrition. We also see other significant abnormalities, including an uncontrolled hyperglycemia. This may be associated with ketoacidosis, but we also may see very high blood sugars with an increase in osmolarity. Hyperlipidemia is frequently observed in the patients when they arrive to the intensive care unit and is due to either the underlying condition or the inflammatory reaction or the contribution of the lipid vehicle provided in sedation, or the three of these elements combined. We also see frequent electrolyte abnormalities with either hypo or hypernatremia. And we have changed our fluid management in these patients. Previously, we would restrict fluids, but in patients with type 1 respiratory failure, we are now a little bit more liberal on fluids. So we are seeing both excess and defects in fluid management in these patients. So in summarizing, the nutritional implications of the clinical presentation in the ICU are important. We know that high PEEP and high FiO2 may be necessary, although high PEEP may not be necessary initially. And in fact, we are trying to avoid intubation in those patients initially and using non-invasive ventilation. We know that when the patient is intubated, we try to use virus filters, and therefore breaking the circuit becomes an important issue. And we also know that CO2 retention is common. Most patients require vasopressors, and therefore we become worried with gastrointestinal perfusion and the development of ischemia. Most patients are anticoagulated, and even though we use heparin currently, if at some point we're going to start using warfarin, we need to be aware that most nutritional formulas, and most either with parenteral or enteral presentation, will contain vitamin K. And in our case, up to 1/3 of patients have required renal replacement therapy, although this number appears to be decreasing, and therefore we have to take this into account. Remember that these patients require strict isolation, and I will say this more than one time during this presentation, and that is that personnel requires personal protective equipment. It is really essential to take care of our healthcare personnel. So where have we come from the nutrition point of view? Where do we get our data to provide the best nutrition support that we can give and the breast nutrition intervention that we can give. They come both from the ASPEN guidelines and the ESPEN guidelines, and I urge you to go to those websites and download those documents. They're important guiding documents. But I want to also offer my personal experience because there are a number of contrasting observations that become important in the real world. Let's talk about nutrition assessment. Nutrition assessment is necessary, but there are a number of challenges that you will be facing. You may have restricted access to your patient because we are trying to isolate these patients and protect our personnel. So we provide and we try to provide cluster care or bundled care with having only one individual or the minimum number of individuals entering into the rooms. In addition, if you look at many of the nutritional tools, such as the GLIM or the MUST or NRS, you find that they really evaluate a risk of illness. And if you look at these patients, they will all or tend to all fall into a high-risk category. So nutritional equations and nutritional assessment may be of limited utility. And on top of that, obesity may be a confounding factor. We know that pre-existing conditions and morbid obesity is important. We know that there may be pre-existing hyperlipidemia. And we know that many of these patients, or a good number of these patients, will have diabetes and will have very difficult to control blood glucose levels on arrival. It is difficult to evaluate the frailty, and not much in the literature is known about the contribution of frailty as a risk factor for the development of severe COVID-19. But it is easily or easier to identify in old age, but is masked in sarcopenia, is masked in morbid obesity as an important confounding factor. When we look at our nutrition assessment, we know and agree with everyone that indirect calorimetry is fast becoming the golden standard of nutrition assessment, and that there's limited utility for other ways of calculating nutritional requirements. However, if a patient is requiring high FiO2, that may limit the ability to do indirect calorimetry, and I will talk more about that. And therefore, we have started to use, timidly, but starting to use ultrasound as a way to address and evaluate muscle mass. Laboratory testing may also be limited because, again, we don't want to enter into the patient rooms and get a lot of samples, and because of the large number of patients limiting the number of laboratory tests that we can do in all of these. Looking a little bit more in depth for indirect calorimetry, IC has really changed my clinical practice. It is important. We are addressing ways of purchasing these equipments and incorporating them into daily practice. But there's challenges. As I had said, as we know, indirect calorimetry is limited when patients have ventilator setups in which the FiO2 is elevated. We also have limitations in breaking and needing to break the ventilator circuit because of the danger of spreading of the virus and aerosolization of the virus. And therefore, we have some limitations with that due to the risk of contamination. The clinical reality also is that we have high numbers of patients. This requires a change in clinical practice. We have to expedite the evaluation of our patients. We may overwhelm the number of clinicians with adequate training for nutrition assessment. And just the sheer number of patients and their isolation may make it difficult to monitor nutrition intervention and to identify whether we are meeting adequate nutritional goals or assess any presence of complications such as gastrointestinal intolerance. In patients that need or require parenteral nutrition, vascular access may be limited. The idea that we have and can have a dedicated line for parenteral nutrition may not be practical or possible. And therefore, just the delivery of parenteral nutrition may be a challenge. So we need to really simplify nutritional assessment and care. It is really important for your institution to develop very simple to follow algorithms that can be followed by people that don't have an extensive training in nutrition. Minimize the complexity of your interventions and focus your team on collecting essential data for you to be able to monitor the largest number of patients at one time. And I will say it again and again, please follow the CDC guidelines for protection of personnel. Roughly, we can divide our patients into 3 categories. Those that have severe comorbidities such as cirrhosis and have a varying age. Those patients that are old age and have sarcopenia, for example, nursing home residents, and they're very characteristic. But the one group of patients that is particularly challenging and has become a significant issue in our practice is the younger morbidly obese patients. These patients frequently come to us with uncontrolled diabetes or hyperglycemia, with an elevated HbA1c, and with either uncontrolled hypertension and/or cardiac remodeling. These patients are where I want to focus the rest of my lecture, although I can answer questions about the other 2 patients and the challenges that appear in providing nutrition intervention in those other 2 populations. I do want to give a great thanks and to say how grateful I am for working here at Ochsner. There is a group of dedicated professionals that have worked with me and worked with us to provide us the best care. Everyone ranging from the highest levels of administration to the janitor has been extremely helpful in working with us. And I'm just amazed at how people have adapted. For example, as you can see, in creating negative pressure rooms, sometimes within hours, as they appear to be needed. So I'm extremely grateful for that. What happens in the non-intubated patients is important. Generally, and again, we have now evolved so that we are not intubating patients as early, and we tend to manage these patients with non-invasive ventilation. We were initially afraid of that because of aerosolization and spreading of the virus and contamination. The availability of negative pressure rooms now makes us a little bit more comfortable, but still there are risks. But we are now using positive pressure breathing such as BiPAP or CPAP more frequently. These patients are generally NPO because of 2 reasons. One is that taking the mask off to use an oral nutritional supplement may result in severe hypoxia in these patients, in a hypoxia that takes a long time to recover. So it may not be practical. Putting an NG tube or a feeding tube may prevent the masks from closing around the face of these patients, and therefore they may promote air leaks. And then because we're worried that these patients will need to be intubated, we really keep them NPO to avoid the risk of aspiration during the intubation process. So we question whether these oral nutritional supplements are they practical or they even possible. We would love to give them, and we agree with everyone that they would potentially be helpful, but they are potentially just difficult to implement, and they're a challenge. What about the ventilated patient? Now in the ICU, what do we do for early care? And the truth is, in the first 24 to 48 hours, we have a number of competing priorities that make nutritional therapy hardly a priority. We are trying to stabilize the patients from the ventilatory point of view. We are providing hemodynamic resuscitation and trying to titrate vasopressors and fluids. We are managing sedation, we're correcting electrolytes, and we're trying to correct metabolic abnormalities, including hyperglycemia, hyponatremia, or hypernatremia. So we are providing a lot of care for these patients. And so even though we, again, agree with the guidelines that suggest that early enteral nutrition should be started, the reality is that in a number of patients, we can't get started before 48 hours. We try to if the patient is stable, but the reality is it sometimes takes us more than 36 hours or 48 hours to get started on enteral nutrition. So early enteral nutrition remains a goal. but it's something that we have learned to temper. We do start at low volumes, and we focus on delivering of protein and not delivering calories. And the reason for that is something that I will focus on in the next few slides. But one of the big reasons is that most of these patients are still on vasopressors, and therefore we want to avoid the development of intestinal ischemia, and we start carefully using low volumes and slowly ramping out to provide adequate nutritional goals. We do restrict caloric intake because it is difficult to calculate, because our patients are receiving other sources of energy, including the lipid vehicle for sedatives, because hypocaloric nutrition is advocated for morbidly obese patients, and because the ASPEN and ESPEN guidelines now focus on protein delivery with moderate caloric restriction in the first week of the patient being in the intensive care unit. So a good number of reasons. No study has, in the last 10 years, has demonstrated that meeting caloric goals at 100% early on in the stay of the patient in the intensive care unit is of benefit and can have complications. So it's far safer to err on the side of providing 50 to 70% of the caloric goals in these patients. That data has been proven by most studies and many studies, but one of the studies is that provided by Sussman, in where you see that a restriction of calories somewhere around 60 to 80% or 50 to 70% is associated with the lowest mortality, while increasing protein delivery to 1.3 grams per kilo per day or higher than that is also associated with a lower mortality. So we use those new goals and have changed our practice to provide that. What tools do we have to provide it? And both ASPEN and ESPEN suggest that standard formulas can be used to provide those goals. But the truth is that they are impractical. The reason for that is that they were not intended, most standard formulas, even high protein formulas, were not intended to provide hypocaloric nutrition, and therefore they are designed to meet traditional caloric goals. They are lower in protein and they are higher in carbohydrates. So we have focused on formulas that are very high in protein and low in carbohydrate, containing up to 37% protein and a decrease in carbohydrates to about 30% of the caloric needs or the caloric concentration in the product. Let's see an example. If I have a 75 kilogram female on Enteral Nutrition and I want to achieve a goal of 1.4 grams per kilo ideal body weight, and I try to use a standard formula with a concentration of 1.5, I would have to give over 300 grams of carbohydrates in this patient, and I would also give a significant amount of lipids. Clearly, overfeeding this patient and getting into the complications of overfeeding. This is in contrast with restricted amount of calories by carbohydrates and lipids that I would give with a very high protein, low carbohydrate formula. At Geisinger, we looked retrospectively on how we were providing nutrition for 2,000 patients. And we reported this as an abstract at ASPEN in 2019, and hopefully will be submitted as a peer-reviewed communication soon. If we look at patients receiving different formulas, either standard, a high protein, or a very high protein formula, we see that when we take into account non-traditional forms of giving nutrients, such as the lipids provided during sedation, or the dextrose provided as a vehicle for some of the vasopressors, we see that the difference in calories is not that much, and in fact is not statistically significant between those three groups. But when we look at the amount of protein delivered, we see that very high protein formulas are very efficient at delivering protein in those patients, and that is highly statistically significant. In fact, if you look at it carefully, we end up giving more than 40 grams per day difference between the standard formulas and the very high protein formulas. And therefore, very high protein formulas are easy to use and are really good tools to deliver adequate amounts of protein. The other benefit that very high protein formulas have is that of an easier control of blood glucose. This is a report by Todd Rice, of which I was a senior author in this article, and we did a phase 2 prospective randomized open label controlled trial. And we demonstrated that people in using very high protein, low carbohydrate formulas had less dispersion of glucose values, had a lower average of glucose values, and decreased insulin utilization, suggesting that we were decreasing insulin resistance in this patient. And thus, these formulas are associated with better glucose control. So by the end of the first week, our goal is to achieve 1.2 to 2 grams of protein per kilo per day ideal body weight. And I will say why ideal body weight. We try to meet 60 to 80% of the calories, again, by ideal body weight. Why do I use ideal body weight and not actual body weight? It is because the high incidence of obesity, that is BMIs above 30, or in morbidly obese patients, BMIs above 35, it makes it difficult to calculate otherwise how many calories I would give to a patient. And the second part is that multiple studies have failed to demonstrate that meeting caloric goals improve clinical outcomes. So we really focus on ideal body weight and simplify the process of calculation so that people that don't have a ton of training in nutrition can adequately calculate the nutritional requirements of our patients. Other benefits include very high protein, low carbohydrate formulas, include the fact that we can give lower volumes of these formulas, up to 1/3 less volumes, and therefore they're easily titrated up or down without trouble for the patients. And it seems that they can be tolerated better, and that they decrease carbon dioxide production. After the first week, and unfortunately it is very frequent that the COVID-19 patients will stay a couple of weeks on the ventilator or even longer. There are still patients that are ongoing inflammation, and as I showed, some of these patients are transitioning to an ARDS and still have very high C-reactive proteins, high ferritin levels, high procalcitonin, all showing that they continue to have a large inflammatory response. There is an unproven benefit of attempting to increase caloric delivery with ongoing inflammatory response, and therefore we try to avoid excessive amounts of calories even in the second weeks. There's really no hard data as to how we should be feeding people after the first week. And there's some schools of thought, those that believe that we have to increase delivery of energy to meet 100% of the goals, and that is important, even in the presence of morbid obesity. Thus, we ignore the underlying metabolic derangements of these patients. And those that believe that increasing protein intake during hypocaloric nutrition still is able to achieve a nitrogen balance, avoid the side effects of excessive amounts of energy, and helps in the long-term management of morbidly obese patients because we are addressing their underlying chronic illness. Those people that have advocated after the second and even the third week of providing hypocaloric nutrition include Raleigh Dickerson and Pat Chauvin and others, and they have demonstrated that when you focus at providing higher amounts of protein, even when you provide lower calories, you can still achieve a positive nitrogen balance. And hopefully by doing that, avoid hyperglycemia, avoid hypertriglyceridemia, fatty liver infiltration, and excess production of CO2. And thus I'm going to leave you with the concept that you should be thinking about how is it that you're feeding the morbidly obese patient in the long term during COVID-19 infections. Parenteral nutrition, we try to use it widely. It is a limited resource. It is difficult to implement, as I said before. but we do use it, and we tend to use it the way that was taught to us by the work by Heidegger and Metaberger and published in Lancet in 2013. And we use it only in those patients that are failing to meet adequate nutritional goals. And again, I say, when I say nutritional goals, I focus on protein goals and not calories. The truth is that in our personal experience, we can feed most patients enterally, and we tend to avoid parenteral nutrition if we can, but we'll use it when necessary and when the patient has adequate indications for its use, including, and I have not talked about that, the very frail patient that is emaciated with both protein and calorie malnutrition. In conclusion, COVID-19 is a complex disease. It is still incompletely understood. Guidelines do give us a set of general principles and are important to follow. These patients tend to have a complex past medical history with metabolic disease generally associated with obesity. There are also clinical characteristics, all of which create significant challenges to provide adequate nutrition therapy. Very high protein, lower carbohydrate formulas may provide a better and easier way to deliver adequate balanced nutrition to these patients. They are easy to use. They require minimum manipulation. That can be used for the first week to meet protein goals and avoid excessive calories. Longer term use, while unclear, there are a number of arguments in favor of it, and we use it carefully, while there are others that would challenge that approach. More data at some point will remain to be seen to teach us what should be the right way to provide nutrition for these patients. I want to thank you so very much. I want to dedicate this lecture to all people at Ochsner. Your work and the selfless participation in caring for these patients is invaluable. And I really want to thank all patients that have come to us with COVID-19 for all that they have taught us. Thank you very much. I want to also thank Nestle for permitting me to give this lecture.
Thank you, Dr. Ochoa. That was excellent and very timely. We have a number of questions that have been submitted regarding the information that you shared. And if you don't mind, I'll get started with some of these questions. Our first question pertains to the use of omega-3 fatty acids. Does the use of omega-3 fatty acids play a role in the nutritional management of the COVID-19 patient?
There's a publication a number of years ago called the VASCAZEN trial, VASCAZEN trial. This trial provided omega-3 fatty acids for patients and was intended for a long-term replenishment of omega-3s. What was interesting is that almost 90% of the people screened in this study, which were obese or had some other metabolic morbidity or comorbidity, were omega-3 fatty acid deficient, or the levels of omega-3 fatty acids were very low. We do not know if an abnormal omega-6 to omega-3 fatty acid ratio is contributing to the hyperinflammatory response of these patients, and it will be very interesting to study. I tend to provide my patients with a balanced omega-3 and omega-6 to omega-3 fatty acid relationship in their diet.
All right, thank you. So Dr. Cho, you and others have discussed the two types of mechanically ventilated COVID-19 patient. There's the ARDS-1 patient that has a lower PEEP level, unlimited tidal volume thresholds, respiratory rate limits that don't exceed 20 breaths per minute, versus that second type of patient, the ARDS-2 patient, who's being treated for severe ARDS using lower tidal volumes, prone positioning, and relatively high PEEP. Does the nutritional support for these patients differ, especially in relation to the high PEEP and concern about oxygenation to the gut? How do these nutritional goals differ for these two types of patients?
There are a few things that are important. I tend to be more liberal with fluids in the type 1 because, interestingly, what we observe is a redistribution of blood flow into the through the lungs, and therefore I try to tank them and give them a little bit more fluid. So I'm more liberal with fluids in these patients. I'm also careful about patients with high PEEP because that has been associated with poorer blood flow to the gut. And so I tend to be careful, and I will reassess patients, particularly as they transition from a type 1 to a type 2 around the second week if their vasopressor requirements are increasing. And in those patients, I will be carefully titrating their enteral nutrition, and will stop it if necessary if the patient becomes unstable.
All right, very good. Thank you. With prolonged hospitalization in ventilated patients with COVID-19 in combination with clustered care and decreased patient contact, there's an increased incidence of pressure wounds. Is this an arginine deficient state then? And if yes, when is it safe to supplement with arginine for wound healing? And how much supplemental arginine should be provided?
That is the question that we are trying desperately to answer as fast as we can. And I'm waiting to see if I can get IRB approval for our study. The first thing that we will be measuring is whether the inflammatory response of patients with COVID-19 is associated with an arginine deficiency state. We know from previous publications that patients with morbid obesity have high arginase activity, and therefore their arginine levels will tend to be lower. And so it is tempting to say we should be providing arginine to this patient. However, we are tempered with the concept that has prevailed that shock, providing arginine in shock states may be concerning or dangerous. And so I do wait for the patients to provide arginine at this point, but I will provide them as the inflammatory response subsides, especially if they have pressure ulcers. It is unfortunate that pressure ulcers appear to be quite frequent because we cannot enter the room and mobilize these patients as we do it normally. So now we're seeing patients with pressure ulcers. In those patients, the use of arginine has been shown by an author called Tim Crow from Australia, have been shown to statistically improve the closure of pressure ulcers when we provide them with arginine. So I do use arginine supplementation. How much? I tend to use somewhere between 9 to 12 grams or even 15 grams a day.
All right, very good, thank you. So Espen describes the acute response to critical illness in 3 phases, 2 of which are catabolic phases, the acute early period lasting 1 to 2 days typically, the acute late period lasting 3 to 7 days, and then the late phase or chronic phase being the anabolic phase. So in these COVID patients, at what point do we advance from trophic feeding of up to 70% of goal feedings to the full 80 to 100% of goal requirements? And when considering when to advance, do you look at lactate levels, CRP, or other markers of inflammation to drive the advancement of the feeding?
So a couple of things. In the inflammatory phase in COVID-19 is very prolonged and is more prolonged than in other patient populations. So this idea that we are over the inflammatory phase in the first 7 days and therefore are going to nicely transition into a second anabolic phase by the second week is not occurring in our patient population, or not easily occurring in our patient population. We do not know how long we can extend some hypocaloric nutrition, but what we do know is that if we provide adequate amounts of protein and higher amounts of protein, we tend to be more protective, and there is evidence that we can reach anabolism at some point with higher amounts of protein and lower calories. So I tend to be careful with the amount of calories delivered to these patients. The other thing that I see in these patients is that they will still not be in the phase where they are going to have increased energy requirements due to mobilization or starting to walk or things like that, and they may not be ready, and that they're severely deconditioned. So I am, again, careful at providing a lot of calories in this patient. That does not necessarily, I do not necessarily approach the frail, emaciated patient the same way. In those patients, I'm far more liberal and try to provide more calories in these patients because they do not have reserves to be mobilized.
All right, thank you. So what is the recommendation around trophic feeding for the pregnant ventilated COVID-19 patient?
My gosh, that's really a difficult patient population. Interestingly, we saw that more frequently in SARS than we are seeing it here in our patient population here. And so the challenges of feeding the fetus and the mom are real. And I do believe that it is important to take into account the metabolic requirements of both mom and the fetus that are significantly increased in this patient population. I would love to be able to use indirect calorimetry in these patients. And if there is any patient population where I would say, well, there is really a need and we're going to break circuits and we're going to go for it, would be these patients.
All right, thank you. So how quickly should we transition to TPN if a patient's not tolerating enteral feeding?
So what we are finding is that most patients tolerate enteral nutrition. And because we tend to use volumes that are not too high, that is, when we are meeting nutritional goals somewhere around 50 to 60 milliliters per hour, or and sometimes even less, we tend not to see that much of intolerance in these patients. So the truth is that we have been able to be quite conservative in the use of parenteral nutrition. We do have a number of patients that exhibit intolerance and manifest it in different ways. And in those patients, somewhere around the first to the second week, we transition them to parenteral nutrition. But we will try again at some point to see if we can successfully feed them enterally. I do provide early parenteral nutrition again in the emaciated patient that comes to me, and the frail patient that comes to me with no reserves. And in those, we do tend to start parenteral nutrition a lot earlier, or significantly earlier.
All right, and that patient who has a number of different fluids going just with the goal to hemodynamically stabilize them, how do you manage that IV line that's dedicated just to parenteral nutrition? Is that a thought when central lines are being placed, or how do you manage that? So
every time we intubate a patient, immediately after, we provide the patient with a central line, and we provide the patient with an arterial line. Any of the patient is showing any signs of renal dysfunction, we provide this patient with a dialysis catheter. So very early, we are aggressively lining these patients. It is not easy because of the number of vasopressors, the number of medications going through the tubing, and we try to use what is called extensions in the tubing so that the pumps can be managed from the outside of the room. All of this, it is just not easy to manage parenteral nutrition, and it is quite challenging. And it may be that we just have to accept in some patients that we cannot have exclusively dedicated lines. We do try to keep that principle, but it may just not be possible in some of those patients.
All right, and in that non-intubated patient that you keep NPO, how many days do you allow them to be NPO before you start considering initiating some type of nutrition support, whether it's placing an enteral line or starting parenteral nutrition?
So along with placing the lines, all of these patients will get an NG tube. And so from the point of view of having a tube, we just feed them through an NG, again minimizing manipulation and placing feeding tubes, etc. And we will start most patients somewhere between 48, maximum 72 hours. So once we stabilize the patient adequately, even if they're on pressors at levels like 0.04 of levofed and 0.04 of vasopressin, we will start those patients generally at 20 to 30 cc's an hour of a very high protein, low carbohydrate formula. And we will ramp up to about 40 to 50 and stay there around that level of meeting nutritional goals by the end of the 5th to 7th day.
All right, very good, thank you. So some patients present with inflammation of the cerebrospinal fluid and they experience brain swelling. Are their caloric needs very high, similar to the head trauma patient? And is ileus a common problem in these patients?
So what we are seeing is a lot of electrolyte abnormalities. And we do think that some of them may be related to derangements in a central nervous system. We do try, in those patients that are identified, we do try to keep a sodium around 145 and be careful with that, trying to avoid more brain swelling. I don't typically see a lot of ileus in these patients from a point of view that it worries me that they're just going to be intolerant to the diet. So most patients I can feed. We also are not using a lot of measuring gastric residuals or things like that, again, to minimize entering into the room. And maybe that's a benefit, maybe because we know that gastric residual volumes are not predictive of tolerance. Maybe it's a benefit, and we just assume that they are tolerating the nutrition adequately.
Okay, thank you. And can you discuss the ramifications of stress hypoglycemia versus type 2 diabetes in the COVID-19 population, and tell us the goal serum glucose levels in these patients?
Sure. So we do not know. I mean, what we see in the critically ill population is that while hyperglycemia is a risk factor for both stress hyperglycemia and for people with known diabetes, the amount of risk is a lot less for the diabetic patient, which is a paradox. They seem to defend themselves a lot better. Having said that, if you look at hyperglycemia, it is still a risk factor in both patient populations. We do not have any study right now in COVID, but there's a recent report that suggests that achieving blood glucose control below 200 or ideally below 180 seems to reduce morbidity and mortality, but it's still a very preliminary report. I do try to hit somewhere around 140 to 180 in those patients. Again, being pragmatic about how tight I would control blood sugars in patients that I cannot even enter to assess, and we're trying to assess for hypoglycemia would be potentially very difficult.
All right, thank you. So how do we feed in the patient with multi-organ failure, particularly acute renal failure and acute liver injury? Do you restrict protein in these patients?
I do not. And I'll qualify that a little bit. Liver dysfunction tends not to go into full-blown liver failure, so it's not as common as one would think that you would see. So it's not being a problem. Second part is access to dialysis. And what we do observe is that when the number of patients becomes very high, that puts a stress on the availability of dialysis. So we have had to learn how to provide renal replacement therapy for multiple patients. So far, we know that the benefits of increasing delivery of protein in people that are on renal replacement therapy outweighs the risks. And so we continue to be liberal with our protein intake in those patients. We do not go too high on them. We don't go to 2 to 2.5 as Aspen guidelines suggest, in part because, again, we're trying to simplify our protocols as much as we can, and we just give somewhere around 1.8 to 2 grams of protein, or somewhere around 1.5 to 2 grams of protein in those patients.
All right, good, thank you. I have a question regarding feeding a patient in a prone position. So there have been quite a number of incidents of patients requiring bolus feeding secondary to shortage of feeding pumps. So what's the maximum amount of bolus feeding you would feed in a prone patient? What's your experience with that?
We're feeding patients that are prone. We are, and we're doing that. when we've run out of pumps is that we do not like the idea, but have learned to do bolus feeding, and we provide volumes between 60 and 240 milliliters every 4 hours or so. If we can, we try to space them every 6 hours, but it depends on the patient. And so we are feeding maximum of around 8 ounces of fluid per bolus, which is not much. It's a small cup of coffee.
Okay, thank you. And I think we have time for one more question. Do you recommend a micronutrient supplementation with enteral nutritional support, IV or through the tube during that first week, or maybe the first 2 weeks of trophic feeding in the very sick patient? And if you do recommend that, how would you give it and what amount?
So the answer is a general no, because I can meet nutritional goals with my very high protein, low carbohydrate formulas with essentially 50 cc's an hour, and I reach that goal pretty easily. So as a general rule, I don't. However, one of the things that becomes interesting and anecdotal information is that we are seeing a significant amount of macrocytic anemias that seem to be underlying. And I don't know if that's just an observation that we're done, if that is true or not, but in those patients, I am supplementing multivitamins separately.
All right. Well, Dr. Ochoa, thank you, and thank all healthcare providers for striving to give the best possible patient care during these challenging days. We certainly do appreciate all of your hard work and the sharing of your knowledge. On behalf of the Nestle Nutrition Institute, we hope that everyone has found this information useful to your practice, and we hope you enjoy the rest of your day, and please be safe.